Therapist Thrival Guide, where we cover all of the things that graduate school didn't teach you. Welcome to the Therapist Thrival Guide. My name is Miranda Barker. I'm a licensed clinical social worker, and I'm here with Dr. Lucas Vellini.
Good to be here. Licensed marriage and family therapist working in franchising, which is relevant today because we have our first guest on the show from Ellie Mental Health's franchise system and network. So excited to kind of add this new element, which is why you're kind of seeing a shift in format. Barker and I are where we usually are. Mm-hmm. But, kind of extending into some episodes that'll be a virtual format so we can start featuring a lot of our therapists from across the country.
Yeah, we have so many therapists across the country that specialize in just some really cool things that we don't specialize in. Mm-hmm. So we're excited to bring some more people on. So I don't know, Claire, do you want to go ahead and introduce yourself first?
Sure. So I'm Claire McGinn. I'm a fully licensed master's level social worker, and I'm the clinic director at Ellie Mental Health in Birmingham, Michigan.
Awesome.
All right. It's a very exciting place to be.
Where is that relative to Detroit, which is kind of like an anchor that people can
we're about a half hour outside of Detroit.
Oh, okay. Mm-hmm. So do you do the thing where you like hold up your hand and you say, I'm
absolutely.
From this part of Michigan?
Yeah, we are that annoying. It's true.
No, I love it. It's helpful for me. I don't know Michigan geography very well, so it's good.
People from Michigan aren't nearly as annoying as people from Wisconsin, so I wouldn't. And with us also, a returning guest who's been a delight to have, Dr. Jasberg. Welcome back.
Thank you.
Where are you coming from today?
I am in lovely Maple Grove, Minnesota.
All right.
Awesome. And if you might remember, but Dr. Jasberg runs our TMS clinic, and mm-hmm. What's your title here at Ellie?
I am I'm a medical doctor, and I'm the senior director of adult psychiatry. And so in Maple Grove, I oversee transcranial magnetic stimulation, and then we're launching first episode psychosis intensive outpatient track in the next couple weeks.
So exciting. So Dr. Jasberg, what interests you about this topic? Today we're talking about schizophrenia, schizoaffective disorder. Curious where you fall into this.
I mean, psychosis has always been my main passion, even since medical school. It's kind of what drove me to want to specialize in psychiatry versus like just planning on being a rheumatologist, something where I like thought about enzymes all day. But when I was on my medical school rotation, I remember distinctly seeing this kid who was 18, 19 and floridly psychotic, and he was admitted, and I admitted him as the medical student. And then within a number of days, he was a completely different person. And so that rate of like improvement was really exciting to me, right? Like you can see it, like it's visible, it's palpable, it's really cool, right? Like, and there's lots of areas of medicine that are really important, but just sort of boring, like managing somebody's glucose or their kidney function, like very, very important. But it's more like watching numbers, right? Where somebody's like pregnant and then they're suddenly not pregnant. There's a baby there. That's like really exciting. So there's different levels of change in medicine, and psychiatry is really big changes, which is really cool.
It makes it more rewarding and more exciting. Absolutely.
So selfishly, it's more interesting for me.
I love it. Yeah. And then Claire, why don't you tell us a little bit about your background and what interests you about this topic?
Sure. So I actually got into social work to work with adolescents with substance use disorders, which is hysterical because I wouldn't want to do that ever now that I've been in the field. My very first job in social work was out in Seattle, and I was working on a mobile crisis team. And there's a huge homeless population in Seattle with lots of various mental health issues. And that was sort of my first experience outside of family experiences with people with chronic and severe persistent mental illness. And I found that I just loved working with people with psychotic disorders. from there, I went inpatient and worked in inpatient psychiatric units for about 10 years, and just, again, loved working with people with psychosis. On one hand, there are the people who get on medications and do wonderfully. And then on the other hand, I've also worked with probably the case that made me want to stay and continue doing this was a young 18-year-old first break. Family was not on board with medical treatment for cultural reasons. And within the span of 6 months, he had taken his own life because of his psychosis. There were no therapists who wanted to work with people with psychosis. The family didn't want to do medications. There just was not that support. And I wanted to be that support, figure out how can we get more therapists doing this.
That's so important and heartbreaking.
Yeah.
I think that one thing that Lucas and I talk about sometimes, and we talked about this on, I think it was one of our very first episodes. We had Zoel Gonzalez on, and he's someone who is also working at Ellie and very passionate about working with people with severe and persistent mental illnesses. And one thing that we talk about a lot is how it seems like people are who are newer to the field are often the ones that are working with people with SPMI, or it's going to be people who are, or maybe they have, people in their family of origin that have struggled with SPMI, or they have different things that draw them to working with this population, and how in some ways it feels like graduate school or maybe medical school doesn't really prepare us for the realities of what it looks like to work with people who have schizophrenia or schizoaffective disorder. And so I'm wondering if we can just take a step back too and talk about what are the differences between these two diagnoses, and what are some symptoms that kind of carry over?
Yeah, and what role does the therapist play? Because this isn't glamorous work. It's like a lot of people get fixated on the posh private practice office, working with people who can kind of come for 1 hour a week. You can address their issues, see some progress, and feel good about that. Whereas individuals that are diagnosed with schizophrenia, classified as severely and persistently mentally ill, they're almost put into their own branch of treatment. Like in Minnesota, it's ARMS work, adult rehabilitative mental health services. A lot of it's reimbursed by state insurance policies and whatnot. And so there can be lower reimbursement rates. And what I think's interesting about schizophrenia, even from the perspective of graduate school, it's in marriage and family therapy, it's interesting because schizophrenia is at the foundation of our profession. Family therapy came to life as a distinct discipline in its effort to start to figure out what's going on with schizophrenia. So in the 50s, the Macy Foundation funded millions of dollars to researchers to try to classify, make better sense of schizophrenia, discover the etiology of it, treatments to cure schizophrenia. And so a lot of researchers were realizing that there seems to be a family component to this, that people would have a schizophrenic episode, they'd be hospitalized. While they're in the hospital, their symptoms diminish, but as soon as you return them home to their family environment, symptoms would reemerge. And so it's such a rich aspect of of family therapy's history, which is interesting because the conclusion of all of that effort was family therapy cannot cure schizophrenia. And so now the standard when you teach marriage and family therapy is that when it comes to schizophrenia and other instances of serious and persistent mental illness, the interventions stop at psychoeducation to support the family and how they can best organize around and support the individual who's struggling. But it's very clear that you cannot approach work with these clients with a lens of curing them, which puts it. And then as a provider, kind of like what Dr. Jasberg was saying, you can see improvement, and that's meaningful and that's rewarding. But I think that turns a lot of emerging therapists off, because who wants to work with a population because it sends a false message that you can't help them because you can't cure it, you can't help them. But that's not the case. That's not what we should be communicating. And so, what does therapy look like with these demographics? And in particular distinguishing schizophrenia from schizoid personality.
Yeah. All right, let's chat. Who wants to dive in on symptoms, or what makes up these diagnoses?
So I have a lot to say on the therapy piece, but Dr. Jasberg, if you want to go first and just
Sure.
talk about that.
And just to piggyback on the therapy not being effective, that was taught from one-to-one therapy, individual therapy standpoint for a really long time. Like, don't waste your time. These people can't participate meaningfully in CBT, which is just false. Could not be more wrong. So people with psychotic disorders do wonderfully in therapy, and they absolutely need it. And family support is one of the main predictors of whether or not somebody will get better and stay better. So yes, is it a lot of psychoeducation? Yeah, but it's also a lot of like peer support from family networks and stuff like that. We have a part of the IOP is a family education group, which is partly psychoed, partly psychosocial support. So we can talk about that later. But so from a diagnostic standpoint, you did say schizoid personality disorder. Are we going to go down that road today, or just stay with the...
No, I wasn't. I was planning. I think they
I
misspoke.
thought that was in the prompt.
No, I think so. We're going to chat about schizophrenia and schizoaffective disorder.
Schizoaffective. Okay. I said schizoid.
Yeah.
Okay. Yeah.
So
not
when I explain like symptoms to, usually I'm explaining it to parents.
Mm-hmm.
I start with this idea that psychosis as a word is like an umbrella term. It's not a diagnosis in and of itself. It's a constellation of symptoms. And there's the kind of three categories of symptoms. There's positive symptoms, negative symptoms, and those are terrible words, but that's what they're called, and then cognitive symptoms. So positive is something that's new that wasn't there before. Hallucinations, hearing things that other people don't hear, seeing things that other people don't see. You can have hallucinations in any of your senses. You can have taste, feeling hallucinations, but auditory and are far and away the most common, and then visual, the second most common. You could have delusional ideas, which is a fixed false belief. So despite evidence to the contrary, the person still strongly believes whatever it is that they think is true. That improves over time as insight improves and as symptoms improve. So delusions are another positive symptom. Delusions can be bizarre or not bizarre. So they could be like thinking that your phone's tapped and people are spying on you. Unlikely, but possible. Or it could be like, in the middle of the night, aliens came in and replaced my legs with the legs of JFK. Like, that just didn't happen. Couldn't happen, right? And disorganized or sort of jumbled up thinking and behavior. So maybe they're really hard to understand. Their speech doesn't really track or make sense, or maybe their attire is very bizarre, or their environment is really disorganized. The negative symptoms are things that were taken away. So lack of spontaneous speech, not really just being able to come up with as much stuff to say, low motivation, low enjoyment, difficulty getting things done, but different than depression. And then cognitive symptoms are really one of the main things that impairs people's ability or speed of getting back to school or work. So attention, working memory, processing speed, and concentration are all decreased after an episode of psychosis. And there's probably cognitive deficits even prior to the positive symptoms. So that's what psychosis means. And then, but that's not in and of itself a diagnosis. It's kind of like saying I have a fever. Then you have to figure out why you have psychosis. Do you have psychosis because you are in the ICU and totally delirious and think that there's bugs on the wall and that the nurses are messing with you? That's not schizophrenia, right? But that's psychosis. Do you have psychosis because you're in solitary confinement and you start hearing voices? So our brains, all of our brains are capable of becoming psychotic. It just sort of depends, and that's like the stress vulnerability model, like what it takes to produce those symptoms. So when those symptoms are present, including both positive and negative symptoms, that in a way impair your functional status. So hallucinations and delusions and trouble getting stuff done, right? And you drop out of college, at least for 6 months or shorter than that, but medications were necessary. That's schizophrenia. So when you think about it, that's pretty easy to meet that criteria, right? And not at all what you think about when you hear, Hollywood trying to tell you what schizophrenia is. another very common problem is the prevalence of substance use. Because if substances are present, you can't technically diagnose somebody with schizophrenia. So if that same exact scenario is happening, but they were using THC, they can't technically get the diagnosis of schizophrenia. So that's substance-induced psychosis, which most of the time ends up being a substance-induced or worsened primary thought disorder, but that's from the DSM where the diagnosis would fall. And then schizoaffective disorder, there's two separate types: schizoaffective disorder bipolar type and schizoaffective disorder depressive type, which means that for the majority of the episode, the person was either manic, so talking fast, thinking fast, impulsive, not sleeping, or depressed, sad, low motivation, all of that. But there was also a period of time when that the acute mood episode was treated. So the mania went away. They were sleeping. They were slowed down, but they were still delusional. Right? So there was still psychosis present after the acute mood episode went away.
Okay, so then for schizoaffective disorder, is there a time frame for that as well? You said for schizophrenia, it's less than 6 months.
It would be the same criteria.
Okay, that makes sense.
So your usual differential diagnosis is bipolar type 1 with mania versus schizoaffective bipolar type. Sure. That's kind of usually the waiting game in terms of, well, it's usually substance-induced psychosis NEC for forever, right? But yeah, that would be the distinguishing. And what I always tell parents is this is technically the definition, right? This is like a board's question. They ask medical students this. I always tell the medical students, you're going to have this on your test. Understand the answer to this question. But when you have a patient sitting in front of you, it's much less relevant. You kind of think about it like this person has depression and psychosis, or this person has psychosis and they happen to get manic frequently. And that's the level of granularity that you need to treat the person.
That's super helpful just to kind of start by diving into some of that information. I want to kind of go back to some of the stuff that Lucas was saying too. And I know that both of you want to kind of piggyback off of, what does the treatment look like for this population?
So from a therapy standpoint, there has, in more recent times, when I was in graduate school, it was kind of like Dr. Jasberg, you were talking about, if you're going to be a therapist, don't treat people with schizophrenia because it will never be cured. And I think that there is too much of a focus on curing things as opposed to making them better. But in more recent times, everyone loves CBT. That's the big thing. There is CBT-P, which is CBT for psychosis, and that is focused more on managing symptoms. So you're trying to work on changing the thinking and the behavior to make the psychotic features less stressful and disturbing to the person experiencing them. And they've shown that with CBT-P and medications and family support, vocational training, as early interventions, it can actually help decrease additional psychotic episodes by about 50%. That was a Stanford study that they've
50%.
done.
50%.
Wow.
So there's a ton we can do as far as improving the overall quality of life, and I think it's this whole notion of you can't cure schizophrenia, don't bother. It's that's so stupid. Because at the end of the day, what do therapists really cure?
Yeah.
It's I'm in the business of suffering. And if a client was like, can you cure my suffering? I'd be like, nope, sorry, but I can help you figure out ways to learn to live with it in a way where, it's it optimizes your quality of life. It's with so many conditions, that's what the goal of therapy is. And so with schizophrenia, from that perspective, it's really not all that different. And there is reward in it. You see the quality.
The schizophrenia data, though, so a diagnosis of schizophrenia doesn't go away, right? if you met criteria, you have schizophrenia, but that doesn't necessarily mean you're symptomatic. So a third of people who get the diagnosis of schizophrenia never have another psychotic episode. So by and large, they're like cured, right? I mean, they are cured and they can taper off of their medicine. So I think we just have this is a bigger topic, but we have a problem with like how we look at mental illness and how it's like this marker that then never gets off your chart. And people are always like, can you delete that from my chart? And I'm like, no, I can't. This is why, blah, blah, blah. But there is some risk management that person needs for the rest of their life. But it's possible to be, in my opinion, completely cured, meaning the symptoms are
like
gone, don't come back.
Remission maybe makes more sense. Something along those lines. So yeah, like there's a lot we can do. But like with SPMI, like you were talking about, a similar thing can happen with personality disorders where it's like as soon as that's slapped on someone, everyone just kind of throws in the towel. It's like, well, you're going to have that for life. Like, that's it. I'm going to go find someone with an adjustment disorder so I can feel more effective as a healer. And I think that is a relevant topic, direction that you brought up, Dr. Jasberg, of a lot of this is correcting the way we view, a lot of the nature of what the nature of our work is, because graduate school, medical school doesn't always do the best job equipping us, with the lens that's going to be most helpful.
Well, and it's stigma. It's, Ellie, the whole thing is ending the stigma of mental health that includes SPMI. It's not just ending the stigma of depression. And there is such a strong stigma around anyone who has ever experienced any sort of psychosis, whether it's schizophrenia or substance-induced psychosis, which, here in Michigan, we've seen skyrocket as we've legalized marijuana. There's a huge stigma, and because of that stigma, people are not wanting to treat people with psychotic disorders, which just reinforces the stigma.
So we mentioned CBTp. We've talked a little bit about medications. What else does treatment look like for people who are diagnosed with schizophrenia?
Family. I know, Dr. Jasberg, you had mentioned talking about IOP and, getting family members on board. That's a huge factor. If people don't have family support, they're not going to do as well. It's just like, you guys had mentioned sort of state funding for people with SPMI, and most of their programs are sort of separate from this therapy setting. In Michigan, it's community mental health, CMHs, and ACT teams. It's all about getting as much support to people as possible. And if that's family, that's ideal. If it's not family, let it be the treatment team, the therapist, their psychiatrist, a support group of people who've experienced similar things. People with psychotic disorders oftentimes don't have as much of a support network as people with maybe other diagnoses have. And part of that has to do with the negative symptoms.
Well, and it's also kind of like which spot in the disease trajectory are you looking at, right? So like the SPMI population, by and large, is older, likely had a delay to treatment. So we're focused on early intervention, right? So we know that from big studies like the RAISE study, which is the Navigate model, which is kind of the best evidence-based manual for how to treat these disorders. So if you can intervene and have a short duration of untreated psychosis versus a long duration of untreated psychosis, your long-term trajectory is much different. So then I look at these people and I think about my patients, and I think about so-and-so who has 2 kids now, so-and-so who's in graduate school, so-and-so who's running for elected positions. Like, you can be wildly successful. And it doesn't have to be that you need an arms worker. It might be that you need an agent because you're a famous actor. Like, you know what I mean? Like the chair of the law department, and I always get this wrong. She's like way up in the law school at, I think, USC. But her name is Ellen Sachs, and she has schizophrenia, and she's on clozapine, which means her schizophrenia was pretty significant. And she is like a Rhodes Scholar, spent some time at Oxford, has a law degree. She's married. She's in charge of the law school. And that could be you. That's what I always tell people. And then I make the parents read her book. Because
that's so important.
What's her book? What's the name of it?
So her name is Ellen Sachs, and it's The Center Cannot Hold, which she's also brilliant. Yeah. So she describes psychosis in a way that's so articulate and so descriptive. That's I think the best book for understanding psychosis. And I think Kay Redfield Jamison's book is really good for understanding bipolar disorder. And then the other book, as long as we're on a book roll, is
I love it.
Javier Amador. So he's a psychologist. His brother has schizophrenia. He got really frustrated with this like cycle of his brother would get better and he'd be in the hospital, he'd be on medicines, then he'd come home and he'd throw the pills away, and they would argue about the pills, and they were just locking horns. They just couldn't agree, because if you're trying to argue with somebody about a delusion, you'll find out pretty quickly that if it's fixed, it's not going to work. But he developed this method that he coined LEAP, LEAP, and he has a whole institute, and it's fabulous, in a book that you can buy called I'm Not Sick, I Don't Need Help. And it's this technique of how to listen, engage, agree, partner. So find out something that's going on with this person's thought, whatever it is. Usually it's the emotion, because you're not going to be able to agree on the facts, and you don't have to. So I don't have to agree or disagree that the FBI is following you, but that sounds scary. And how can we move together in a partnership to address this thing that we agree on? And so it's a very like instructional, very easy read, and it just sort of describes some common scenarios that you might run into. Very helpful.
Well, it's just so funny, piggybacking off of that it's connection. You're connecting with someone. It's just like what we're taught to do as therapists. What is the emotion? What you're feeling may not be rational or sound rational to me, but I can relate to that feeling. And that's exactly what we're doing with all of our clients, not just people with psychotic disorders.
And so there's still that component of just like the basic human element to the clinical work, and it's like that doesn't go away. That doesn't change. And I do just want to highlight something you acknowledged, Dr. Jasberg, a moment ago, of like, if someone's delusional, don't try to talk them out of it with reason.
Depending on level of insight, right? Like if the delusion is really fixed, you can try and poke at it and see if you're getting anywhere. But if you're not, then switch to that LEAP method. But as people get better and their insight improves, and by the way, insight is not denial. Insight is part of the illness. It's a symptom, probably like related to precuneus function. But
so like a inability to garner insight is a symptom?
An inability to understand that you're sick, right?
Okay, yeah.
They're not being stubborn. It's not computing. Yeah. It's like if you walked outside and I told you the sky is green and you're like, no, it's not. But I'm like, well, it is. Like, it's
I'd probably take your word for it.
Yeah. So no. But as insight improves, because insight is not fixed, as insight improves, you can start going back to the CBT that Claire was talking about, like how realistic is it that that car means somebody's following you? Or is it possible that that's just a really common car? It's a green Toyota Camry. Lots of people have that car. Is it just possible that you see that car every once in a while because it's a really common car? Right? But that's changeable. I mean, that's back to things are partly biochemical and partly neurocircuitry. And doing that CBT with somebody who has partial insight is driving the circuitry in the right direction. We know that therapy changes our neurocircuitry. We have the fMRI or whatever, borderline personality DBT studies. So that's real.
Is this something, just while you were talking, I was curious, is this something that can be treated with TMS yet?
Not yet, but it's being studied. And brain stimulation for especially hallucinations is really compelling. There's also data in like the tinnitus world about that as well, because there's probably some similarities between ringing in your ears and hallucinations, right? Because it's a sound that's being internally produced.
Huh. Oh, that's fascinating.
I can sense you holding back your excitement about this
I can't wait.
research.
I'm going to be the first person
I
with
love
that
it.
helmet. Don't worry.
So you said insight is not fixed. Is that something that improves naturally? Something that would improve with medication? Something that just kind of ebbs and flows?
Yes.
All the things.
There's this psychologist, what is his name? Dr. Freeze, I think, Freese, something along those lines. But he's a psychologist. He has schizophrenia. And so he wrote about his experience and said something along the lines of like, it took me until my 6th hospitalization to realize I needed to keep taking these meds. He's highly educated in the field. And it took that many times for his insight to get to the point where he was like, I need to be on these medicines. So medicines help, CBT helps, family involvement helps, all of that helps.
I'm curious. I mean, we've talked a little bit about family involvement. What kind of family involvement? How can families support people who, like loved ones who have been diagnosed with a psychotic disorder or with schizophrenia?
So I think there's a lot of different ways. And it depends on sort of where on the spectrum people are. For some people, I have worked with family members who have loved ones who have been on medications, they aren't working, won't stay on medications. It just seems like it's something that's not going to be getting better. I've done a ton of grief and loss work with these people. Sure. You know, I think people, you know, this person's still alive, they're still here, so what is it that you're sad about? But, you know, as a parent,
like the ambiguous loss.
Yes. Yeah. I had, you know, I had a whole future planned out for my child and the way that I saw their life going and how happy they were going to be. And now that's crushed, and that's huge. But then I also think for some people I've worked with, if there's a lot working on family dynamics, you know, if you have a young person who is 17, 18, they were just off at college, they were doing their own thing for the first time. Now they're having to move back home as they're getting treatment, and how can families support without being overwhelming? There tends to be a lot of conflict in that relationship because the parents are wanting to parent and the kids are still teenagers and are telling you, you know, I've had enough. I don't need you staring at me every day. I don't need you making sure I take my medication every day. So navigating some of those conflicts within the family is part of a lot of what I've done as well.
Have either of you, I came across this at a conference maybe like 6 years ago, and I'm not certain on what they called it. It was a team of researchers out of Canada. I want to say it was called the Open Circles program, and they were doing a trial of getting individuals who have been diagnosed with schizophrenia off their medication and providing them a form of group therapy where it more so teaches them to live with their delusions or hallucinations as opposed to trying to resist them or make them go away. And last time I checked on the research, like they were demonstrating some positive results and some interesting findings, but I just haven't kept up with it. Are either of you familiar with that one?
I very briefly read some information on, I don't know if it was that study in particular, but I know a lot of people in the CBTp world, well, maybe not a lot, but there are definitely some people in that realm who think that getting off of medication and just doing that and teaching people how to essentially manage their symptoms so they're not as distressing is all that's needed. I would argue
like
that's
Hearing Voices network that shows up at most conferences. And
oh, what was that? Say that again.
Hearing Voices. They like, yeah, they kind of show up at conferences and antagonize psychiatrists. I mean, you have like good data on like the duration of untreated psychosis is it produces an increase in your ventricle size, meaning brain loss. So we look at psychosis as neurotoxic. So that's why you want to shorten the duration of untreated psychosis. Now, I can't put your brain in an MRI and say that you've had brain damage from psychosis, but if I put 1,000 people who had less than 2 years of untreated symptoms and 1,000 people who had 20 years, their brains are different. And the goal is to come off of medications at about 2 years for schizophrenia. And then, like I said, a third of those people, it never happens to them again. But this idea of like coming off while symptomatic is not ideal. And on the other hand, if you have schizophrenia that's very, very difficult to treat, that's not gone on a multiple medication regimen, and the side effects are really strong, then I reduce people's medicine and kind of find that balance of like, what's your quality of life? How can you manage these symptoms versus the side effects that they're causing? Where do we want to land? Right? Which is why you need to have a good relationship with your doctor, because the number one predictor of treating the symptoms and being in full recovery is taking your medicine. And the number one predictor of taking your medicine is having a low side effect burden and a good relationship with your prescriber. So that's where like that rapport, and sometimes it's the therapist that has the better relationship because they're not prescribing the medicines, but that us as a team, if we have the good rapport together, I'm going to tell your doctor that this is bothering you. This is going to be important to them. And then they tell me the side effect. Then I can say, I hear you're really sleepy or whatever it is.
I mean, that just emphasizes the importance of that team. And I think with a lot of the different diagnoses that we're covering this month and just in the coming weeks, we're really wanting to emphasize how prescribers and therapists can be working together to help clients with their quality of life, coping with their symptoms. And yeah, that communication is just so key. And I think especially for diagnoses like schizophrenia, it just sounds like making sure that the team is communicating is pretty key. What about, you've touched on this a little bit, but what about if you're a family member or if you're a therapist or maybe you're like a child protection worker, I'm speaking from experience a little bit, but and you are working with a family with someone who has schizophrenia and they are just kind of all over the place with taking their medication. What are some tips or ideas that you guys would have for that medication compliance if they don't have that insight yet?
I think a huge part is figuring out what the resistance is and working out from there. Yeah.
Yeah, you always try to start, before you make any recommendations, you try to ask as many questions as you can, especially when insight is unclear. You want to get as much information from that person as you can. So what happens when you miss? What's going on? Is there problems that are making you want to miss it? Blah, 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 blah. Because then maybe the answer is, I really want to take it, I just can't remember. Then long-acting injectable is the answer. Maybe the answer is, I don't actually really think I need this medicine. That's a different conversation. And there are mental health laws that can require people to take psychiatric medications. But at the end of the day, how does a law make you take the pill? It's still the conversation. Yeah. It's still the problem solving. It's still all of that.
Well, and even with injectables monthly, how likely are people to remember to go monthly and get injections that they don't want? Even if it's not a daily pill.
So that's another area where like social support and the family system probably plays a pretty significant role in part. And again, just kind of helping the family reorganize, around the realities that the individual is dealing with to best support them, while at the same time developing resources for their own, distress resulting from the situation. And I imagine a huge part of the psychoeducation with family work is correcting a lot of the misteachings on schizophrenia, because if therapists are at the master's level are largely, misinformed, I would say at this point, when it comes to their graduate training, we can assume that the general population is even more so misinformed about whatever, it's like they've seen The Beautiful Mind. And that's as deep as their understanding of schizophrenia goes. Which, by the way, would either of you say that movie properly captures the lived experience of schizophrenia?
Good question.
I don't remember.
John,
He does. I don't remember the details of it. The Black Swan is fairly, I mean, in terms of Hollywood, close.
Really close. Oh, interesting.
I wouldn't say really close. Maybe the best.
But yeah, less over the top, less
Certainly,
fear-mongering.
I've never seen that movie.
That's a good movie.
It's good, but I mean, and then I'm back to my books, but Ellen Sachs is the best. She's the best.
Yeah.
And she has TED Talks if you're not in for a novel, you know. But well, I guess
nice.
it's not a novel. It's nonfiction, but.
Mm-hmm. I'll add the links in the description to all the books that you're talking about, because I love being able to add resources and being able to share these. I mean, I obviously have so much that I could learn about this topic, and so I'm really intrigued by
I'm not
the story.
Sponsored by any of these.
Yeah. Sponsored by. I'm just kidding. That's perfect. It looks like you have a question. What's going on?
I mean, I've been like waiting for the right time to derail this whole conversation.
Oh, okay.
Into
Here we
conspiracy.
Oh no!
Bring it on.
I think we haven't addressed conspiracies yet on this podcast, which I think is a disservice to.
Which is surprising, because we spend a lot of time talking.
Yeah. Surprising, and it's time to put that to an end. So, you know, and I do think there's some arguably credibility to this. But like when it comes to delusions and hallucinations, the medical field totally rules out like the spiritual realm and all of the possibilities that may or may not exist there. And when I sit back and wonder about, you know, it's like, why haven't we had a prophet in a really long time? Because I feel like we could go for one. You know, it's like, there's less stuff going on in the world. It'd be great to have a prophet, you know, kind of come in and help us, you know, look beyond the circumstance. But like, if we did have a prophet right now, we would diagnose him with schizophrenia, as opposed to identifying them as a prophet. Not necessarily, but there's a probability that at a young age, you know, when their prophecies start emerging, the parents are going to be like, what is wrong with my child?
But the caveat there, because that's described, right? Because hypereligiosity is a symptom, and it's common in mania as a grandiose symptom. Hypereligiosity is a symptom, and we're taught to distinguish it from normal religious beliefs by whether or not other people in their same culture would believe that that is also true.
Ooh, I like that.
Okay,
that's good.
If there's a person who thinks they're the prophet and their entire church of thousands and thousands of people also believe that, then you couldn't technically diagnose that as a delusion. And the other thing that's interesting is there are also some cultural delusions that are different in parts of the world. So
that brings us to the whole Waco, Texas.
That's immediately what,
Did you go right there too?
Yeah. Oh, yeah.
It's all over all the streaming platforms.
Mm-hmm.
So like even when someone has like a group of followers who acknowledge them as a prophet, then we just call them a cult leader. That's a threat to the nation's interior. And we need to manage it and take care of it. But I appreciate what you're saying. I think I've never heard that distinction before. But I think that that's a good clinical tool to at least get a tighter grip, you know, on what is or isn't happening here. Because another thing that graduate schools don't equip us well to manage is like the role of spirituality and religiosity. And I think it's because exactly what you said. I mean, these are things graduate schools, I feel like they just don't teach it because it is too political. It's too sensitive and they just don't want to go there. So it's like the reason they don't teach it isn't for clinical purposes because it's irrelevant. I feel like it's more just like for cultural, political purposes, they avoid it.
But what I always tell medical students is that like you need to understand the definition of hyperreligiosity, and then you need to humble yourself to realize that you're not going to be able to understand that in every culture and in every religion. So once you are suspicious of some sort of hyperreligiosity, you're tasked, you must ask family, ask a cultural reference, like, is this what you believe? And if the answer is yes, that's very traumatic. I mean, I had a patient who was talking about this like particular type of fairy, and I didn't understand it, but it wasn't psychotic. It's just sort of like how this culture talked about this sort of spirit that follows them and does bad things or good things, and it's totally culturally normative to other psychotic symptoms, but that one was not psychotic.
Yeah, I think that religion and spirituality is something that I personally tend to just lean into. I think that spirituality for people can have a really positive impact, and it can give them a really big support network. And so regardless of what religion it is that they're prescribing or a part of, I want to encourage that. But you have to walk that line of what is maybe a normal following of this religion versus what is something sort of above and beyond. And I think too, allowing the client to lead that conversation in some way. I was just having a conversation with a client this morning who believes that his psychotic episode was due to some sort of like spiritual nymph, which is culturally appropriate. And asking me, do you think this is all science, or do you think there could have been some religious aspect? I'm like, I'm not a religious expert. I don't know. This is what I see from my viewpoint, and this is the science that I see. But if this is what your culture is telling you happened, that's fine. You're taking your medication, you have good support, you're coming to therapy, and you're talking. These are all positive things, regardless of my views on religion. So I think it's something not to shy away from, but definitely to figure out how to make distinctions. Just like Dr. Jazz, you were saying before, it's about what is appropriate in different religions. I mean, I remember in Michigan, I don't know how the laws are in Minnesota, but in Michigan, we have people who are involuntarily detained in inpatient psychiatric units. After so many days, we have to take them to court. And we almost lost a court case because this woman argued that she wasn't eating and was no longer getting out of bed because her religion told her to. She wasn't actually, and the judge is like, well, this is a religious thing, so she's allowed to starve herself to death as long as it's religious. And the psychiatrist had to argue, but she's not any particular religion. She's making this religion up as she goes. It's not, her family isn't like she was raised very religiously. Yeah. So it is a fine line. And also,
we're cognizant of not medicating, interesting ideas. But I have patients with hypereligiosity who at baseline are usually religious people. Mm-hmm. And the conversations that you have with them after is very interesting because they still have those religious beliefs and may still feel like they're communicating with God. And that never went away. But then they'll say, but this part of what I thought didn't make any sense. So they can recognize that, right? And so oftentimes religious delusions are very difficult to treat also because patients perceive them as very pleasant, very a gift, a blessing. Why would you ever want to take that away from me? Yeah. Right. And so I always say that it won't change your connection with God. That will remain. But if there's a part of this that's jumbled up, that could get better.
Well, I hate to cut in, but we're just about out of time.
This was so interesting.
I know, you both are so brilliant, and I could not have asked for better guests on this topic. This has been so good.
And not only interesting, but I learned a lot. I was carrying a lot of, I want to say misbeliefs, but there's obviously a lot going on in the field and the profession relative to these diagnoses that I had no idea about. And because it's rare that I get exposed, to kind of this knowledge. But it's got me thinking about a lot of stuff. And yeah, it's great. And it makes me more hopeful.
Yeah.
It really changes my perspective on SBMI. And I think there's a lot we'll be able to do as far as influencing kind of a national narrative that starts to correct a lot of these misteachings and whatnot. So yeah, this was great.
Thank you so much for joining, both of you. I really appreciate
And
you.
for the record, Dr. Jasberg showed up today expecting to talk about bipolar disorder.
I did.
She's just
so that's why if, Dr. Jasberg told me the sky was green, I would say, Dr. Jasberg, tell me everything else I've been wrong about.
I love it.
Dr. Jasberg, you should read your emails.
Well, I'll just end this with a quick shout out for Michigan people, based on psychosis. There's a book. It was actually, I believe, a case study. It's called The Three Christs of Ypsilanti. Ypsilanti is a city in Michigan. It's actually where I grew up. It's a case study of 3 people who are on an inpatient psychiatric unit at the same time who all believed that they were Jesus. And it's just, and how they interacted with each other. So it kind of ties in, Lucas, with your question about the coming of Christ. So we'll add that to the book at the end too.
I love it.
I appreciate your guys' time so much.
Yeah, and thank you for being our first remote guest and opening the door to clinic directors and therapists nationwide to start coming aboard and sharing their knowledge. So this was great.
Thank you, guys.